Now we're going to spend some time talking about the management of ADHD and what our goals of treatment are going to be. So when it comes to managing ADHD, treating it based on symptoms is most important. So symptom coverage throughout the day is one of our primary targets. However, some of the medications that are really helpful in managing ADHD can also come with some side effects or adverse effects. So addressing those and managing those are really important as well. Finally, of course, any sort of treatment for mental illness, quality of life. So really that shared decision making, really working towards patient-specific goals, what they're trying to accomplish, and at the end of the day, making sure that the interventions that we're providing are resulting in an improvement in their functioning, an improvement in their own quality of life and goals. So there are some non-medication options that are available that can be helpful in management of ADHD. Most of these are behavioral type therapies. These are particularly beneficial for the whole family. So if someone has a child with ADHD, we want to encourage them to do things like parent training and behavior management. And this helps to kind of create structure for things like appropriate use of timeouts, appropriate types of reinforcement, and just helps to create a nice structured, consistent environment to help an individual with ADHD do the best that they can. We also have things like behavioral classroom management, psychoeducation, which is incredibly important, especially for parents who have children with ADHD, to help them kind of understand what's going on with their child and how to better, help them through their experience with that. In particular, if we combine non-pharmacological or non-medication options with these with medication, then we can see kind of a cumulative benefit in a lot of situations. So lower doses of stimulants may be needed, changes in performance and satisfaction, kids tend to do better. And these types of interventions can be helpful on the adult side too. We'll mention it in a little bit, but currently there's no recognized adult ADHD guidelines. They're in the works. They should hopefully be made available in the next year or so. So hopefully we'll get a bit more consensus guidance about how to manage adult ADHD, especially from the non-pharmacological side. Now, one area of interest that a lot of families will bring up are things like dietary and nutritional-based treatments. Now, of course, if someone has an intolerance or an allergy, those should be taken into consideration and avoid products and foods that have those. However, when looking at things like dyes and gluten and all this stuff, the data is somewhat mixed and really does not compare to things like medication treatment. That being said, if someone is interested in doing things like reducing red dyes and they're able to do it and not sacrifice the quality of life of the child and sacrifice, things like cost, etc., it's okay to do, but in general, it's not going to be a recommended first line choice above other more evidence-based treatments. So what do the guidelines say? So it's a bit broken down by age, and again, really focusing on individuals under the year of 18 years, right? So first line, if someone is less than 6 years of age, is going to be non-medication stuff. Okay, so things like the PTBM, as we mentioned before, evidence-based classroom interventions, those psychotherapeutic interventions. Ages 6 to 12, we start with a stimulant. These guidelines are pretty straightforward. Stimulants really are an impressively beneficial product for most individuals who have ADHD. I personally prefer using methylphenidate products first. They just tend to be a bit better tolerated. There's a lot of different options for products that we'll spend some time going through as well. Ages 12 to 18, of course, same thing. FDA-approved medication with adolescent's consent. And then second line, so if those first interventions aren't sufficient in that age 4 to 5 range, methylphenidate will be the first option there. Once we kind of get past the stimulants, if for some reason tolerability or benefit just isn't well established for kiddos with ADHD, then we can start reaching for non-stimulant options, so things like atomoxetine, guanfacine, clonidine, but really stimulants are king here in most cases. If we do use stimulants in our younger kiddos, there is an increased mood issue potentially. So things like mood lability or dysphoria, that kind of like zombie sad kind of feeling. And there's an increased risk of weight loss. So we try to avoid, again, medications if they're under 6 because they're a bit more sensitive to them. For our elementary age kiddos, stimulants, right? So the straightforward stimulants really do work, and they don't work in, for most people in the same kind of way that we'll see for, people who take stimulants for other reasons, like to promote wakefulness or, for things like binge eating disorder, etc. Most people who take stimulants at an appropriate dose for ADHD don't feel that like boost of energy and like hyper focus and like I can do anything. It's more of a smoothing kind of effect, for a lack of a better word. So a lot of times it helps them kind of click things into place. It helps them to be able to regulate their impulses and emotions and actually like guide their own attention. So it almost has a calming effect in a lot of ways for individuals who have ADHD. Of course, every brain is different, so that's not always the case for every single person, but that's the most common experience if a stimulant's going to be a good medicine for that individual with ADHD. From there, atomoxetine, then guanfacine and clonidine, those are options as well. And for our middle and high schoolers, we want to truly assess for substance use challenges first. If they do have a substance use issue and have a strong diagnosis of ADHD, a lot of times there should be oversight from some sort of specialist. So if we're talking to a generalist population here, really thinking about using a psychiatrist to assist in the prescribing of those stimulants. Now, when looking at adults, there are a couple different good resources that kind of talk about special considerations for our adult population. So these are some of the recommendations that have come from those individuals. And I like most of these. So we'll kind of go through these really quickly. So for coexisting health conditions and substance use disorders, we want to think about sort of a delineation of what's the most concerning or the most, significant challenge, and oftentimes should address those first, right? ADHD can be debilitating, but oftentimes not associated with significant mortality, right? So thinking about conditions that result in high mortality and managing those as a priority, okay? We always want to make sure we're assessing for any contraindications for stimulants. So we'll talk about what some of those are. Non-drug options, absolutely appropriate to offer for our adult population. And then just using, appropriate precautions when it comes to utilizing your prescription drug monitoring programs, right? Especially if someone is first starting, you want to start with those monthly prescriptions, okay? Consistent refill days if someone has trouble when it's 30 days and it lands on a different day of the month. So thinking about if it's a 4-week, sometimes that can be helpful. Screening for substance use disorders and making sure that those are stable and appropriate before starting stimulants. A lot of patients do better, especially if there is a substance use risk with longer acting stimulants, because it's the on-off effect is a lot smoother if you have a longer acting stimulant. Non-stimulants, if they have a more recent or greater concern for stimulant use or substance use, so things like norepinephrine reuptake inhibitors, like our atomoxetine, can be helpful in those populations, but most of the non-stimulants aren't as beneficial in our adult population. Okay, and be appropriate when it comes to setting up expectations, right? So stimulants usually actually work pretty quick. That's a nice thing in psychiatry. We don't see that often. So stimulants, most people are going to get a good idea of how they're going to do on it within the first couple days, because it really is designed to come on, work for a specific period of time, and then wear off by the end of the day. So unlike other medications for mental illness that are often trying to influence long-term neuroplasticity, stimulants in particular don't really function that way, right? They're symptom management, okay? If they're doing well, we want to just continue on with that for 3 to 6 months, making sure that we're having those check-ins within 3 to 6 months and really typically going to do it at least in every 6-month check-in for people. If they don't do well, consider changing the medication, adjusting the dose, the formulation, if it's a window of efficacy problem. If you're struggling to find a product and a duration and a schedule that works well for someone, again, that's another space where we want to try to refer individuals out to a specialist. So when we're thinking about comorbidities, as I mentioned before, there are considerations here, right? So we want to treat the most impairing disorder first, because a lot of times if you're making a lot of medication changes with especially mental health medications and something goes really well or really not well, it can be hard to know what did what. So whenever able, trying to make one medication adjustment at a time and having that, 1 to 2 week follow-up is more beneficial than, throwing 3 or 4 things at someone at once and then not really knowing what's doing what there. So if someone's experiencing psychosis, we absolutely need to take care of that first. If they're having unstable bipolar illness, want to make sure that they're stable before we start addressing their ADHD. Same thing with things like substance use disorders, mood disorders, anxiety. Anxiety is a little bit tricky because anxiety and ADHD can kind of overlap in terms of symptomatology. And some people, when you treat their ADHD, their anxiety goes away. Right. For others, if you treat their ADHD, it can worsen their anxiety. So that's one that often kind of co-mingles with itself, especially when we're using stimulants to treat their ADHD. So when we're looking at the selection of medications, this is kind of our quick overview for our peds, for our individuals that are on the younger end of the world, right? Stimulant, number one, I repeat myself, right? Stimulant, up to 75% of kiddos will do pretty well, even on their first stimulant. Second stimulant, if it doesn't work. Oftentimes you can go out of class. So if you do methylphenidate first, trying to find the right formulation. If we just can't be successful in the methylphenidate, then switch to an amphetamine product. Okay. After that, try another stimulant or consider doing things like augmenting strategies. So adding a stimulant and a non-stimulant, typically one of our alpha-2 drugs like clonidine or guanfacine with a stimulant, or consider something like an atomoxetine. Now in our adults, stimulants, use your stimulants unless there's a reason not to. Atomoxetine, now these guidelines don't have the viloxazine, the Quellbri, which is very similar to atomoxetine. It's just a newer product. So that one can be considered as well. And then third line, there are suggestions to use bupropion or Wellbutrin, which is an antidepressant, but has some data to support that it can be beneficial in ADHD. So if someone who's an adult is experiencing, for example, depression and ADHD, bupropion might be an option to consider offering for that individual.